Hello, today we shall have a quick session on one of the conditions that we commonly see. We call it EDV in short term, but it is actually Epidermodysplasia Verruciformis. So this is a condition that can either be acquired or genetic, and commonly in our setting, because of the endemicity of HIV and the immune suppressive conditions that we usually see, it is quite common, though not well documented and not well characterized. And it is one of the disturbing conditions that we commonly see. And today we shall shed more light on how it comes about and the proposed treatment options that can improve the quality of life of the patient, even though it is not curable. So as you can see in this picture, we see a young adult in this first picture with this flat-topped verrucous eruption on the body, as you can see here on the back, more or less generalized with some feature of coronalization, where the rash develops on areas of maybe injury following a linear pattern. And in this other picture, we see someone with extensive involvement of the hands with nail dystrophy and this hypopigmentation in the background of. We also have some hyperpigmentation of the skin with this extensive involvement we see here on the leg as well. So Epidermodysplasia verruciformis is one of the rare genetic dermatological condition that usually is characterized by a compromised immune response to specific human papillomavirus infections, especially the beta group of the HPV virus. So because someone cannot fight off this infection, they actually end up with this persistent infection of HPV virus, giving rise to this persistent verrucous plaques that can spread to involve the entire body. And these patients, because of this low immune response, they also have an increased risk of developing cutaneous dysplasia as well as malignancy, especially the SCC, the squamous cell carcinoma. So in the pathophysiology, so this condition has been established to have a connection with the virus of HPV and carcinogenesis. And we know that when you have an infection with HPV, you have watched our previous video on HPV, you will see that this virus can establish latency in the skin. So if someone is immune compromised, it will not spread, it has no cure, and then cause this persistent verrucous plaques. So because of this continuous transformation of cells that are infected, you end up increasing the chances of developing cancer cells. So there's an increased risk of cancer in this patient. And the most common type of carcinoma usually seen is the squamous cell carcinoma, but other tumors like the basal cell carcinoma, melanomas have also been reported in different case reports. So, and the clinical manifestation, so someone will have this persistent verrucous rashes, which sometimes may be flat and confused with pityriasis versicolor. But the difference is, in this case, some of them, they will be warty, and even when you treat with your antifungals, they will not go away. So it is associated with increased risk of getting cancer, and then also bowel disease development, the squamous cell carcinoma. And even when you take off a biopsy, you will see that sometimes the cells have some level of atypia. So EDV has been classified into two, where we have the classical type, also called inherited or primary epidermodysplasia verruciformis, which occurs as an autosomal recessive disorder, but sometimes it occurs as secondary, which we call acquired type of EDV, and this is commonly seen in patients infected with HIV or any other immunosuppressive therapies or conditions, like maybe transplant patients who are on chronic suppression and also chemotherapeutic drugs. So the etiology of EDV has been associated with immune reduced immune response to human papillomavirus, especially the type 5 and 8, which contributes to almost 90% of the cases. Then other types that have been implicated include 3, 9, 12, 13, 14, 15, 17, and the rest, so many. But remember, the common ones is type 5, HPV 5, and then HPV 8. These other ones are the rare ones. Then in these patients, usually the major issue is that they have a defect in their genetic component in a gene we call the EVER1 and then EVER2. Now, because of the defect in these genes, these patients cannot fight off the HPV infection, so they end up getting the disseminated type of these infections. So as we've mentioned earlier, the common one is 5 and 8, then others are the rare type, because these two cause up 90%. And in the acquired form, it's often thought that the immune suppression is due to the infection that is ongoing. Maybe if someone has HIV, maybe because of the immune suppressive effect of HIV, so now someone ends up with this development of these warts. Then the genetic mutations that are specific in this case, the others that have been linked, including the mutation in the raw gene and then STK4, which may also play a role in the development of this condition. But what you have to remember here is that in the genetic form or in the inherited form, it is EVER1 and 2. Then in this immunosuppressive patients, it's usually actually the immunosuppressive state that triggers the eruption to occur, but with some few genetic mutations that have been associated with it as well, including the raw and then STK4 gene. So in a case report, one case was reported to develop after trauma, and in this case, it was from hair removal, and then someone developed these extensive lesions. Then another case reported it occurring after pancreatic transplant, and also renal transplant. So in this case, you have the transplant patient being started on immunosuppressive therapy, and then this allows for the progression of the HPV infection to give you the picture of EDV. So EDV is a little bit rare in literature, but I think it is underreported, whereby they say approximately only 500 cases have been reported globally. But this literature was as back as 2017, and I think it's out of underreporting because it's a little bit more common than reported. Then when you look at the onset of these lesions, usually they occur in early childhood. For example, for patients who are infected with HIV from birth, you'll find that they develop these lesions as early as about 3 to 4 years, then they will persist throughout life. Then the cancer risk, we've said that EDV is associated with the development of cancers, especially if someone has the beta type of HPV infection. And these cancers, commonly, they are the non-melanoma skin cancers, that is the squamous cell carcinoma, and then also the basal cell carcinoma, but commonly it is the squamous cell. Then it has no gender or geographical bias, it occurs everywhere, but now it is more prevalent in areas which are endemic for HIV, including Uganda. In the pathophysiology, so in this case, you have a diminished ability to clear the HPV infection that leads to persistent infection, and then the cancer progression is usually due to the beta type infection and is due to the infection of HPV. We know that when infected with HPV, that infection does not go away and it causes continuous proliferation of your cells. So because of that, there's increased error for you to develop the cancer. And then remember this mutation of EVER1 and EVER2 genes that are in genetic type. And then you remember the STK4 and the rho for the acquired type. However, even up to now, the exact role of EVER gene is not yet established. So it is still a gray zone that maybe some people think there's a potential effect on the zinc transporters that ends up affecting the intracellular zinc levels, interfering with viral infection mechanism of the body, but still not yet confirmed. So when you take off a biopsy, In this case, the classic features of EDV will include moderate acanthosis and then hyperkeratosis, and then sometimes you'll see these large giant blue-gray cells with a perinuclear halo, and often times you see these plastic changes, and particularly if someone gets the condition after a kidney transplant. So more commonly, you can also get irregular granular layer with a rare perinuclear halo. So as you can see in this histology diagram, so this is a snapshot of how the histology will look like. So you see this elongation of the cartilages, which is also here in this and on that red ridge. But then when you look at the cells closely, you see now this keratinocytes. For example, if I take one, maybe let me take which particular one. Let me first magnify, and I take for you one. So if you look at this keratinocyte, this particular one, maybe you see that around the nucleus there is also a halo, or this whitening around the nucleus. So you have these giant cells which have this nucleus having a whitish surrounding, and then you see dysplasia as if the nucleus is dividing here, even here, even here, even here. So you'll see this plastic changes, and then you see this, even this one's a giant keratinocyte, even this one's another. So this is how the histology picture will look like in cases of EDV. So still, this is another picture which shows you the same. You can also look through and then see if you can identify the features that I've talked about. Then when you do a dermoscopy on these EDV lesions, you'll see that it will show you yellowish or whitish scale, often seen with the hyperkeratotic lesions, which are sometimes well demarcated and hypopigmented, as you can see here. So that is how the lesions will look like under the dermoscope. So the typical presentation, sometimes you can see areas of pigmentation in some of the lesions, like here you see this hyperpigmentation inside the lesion. Even here you have that hyperpigmentation inside the lesion. So what are the treatment options? So EDV is one of actually the most challenging dermatological conditions to treat, and it gives this a picture where someone looks at their skin and they don't like their skin, how the skin looks like. It has a great deal of impact on the social economic status, the psyche of the patient, and the rest. And you find that unfortunately there's no definitive cure, but sometimes we recommend these different treatments to try and improve actually the quality of life. So surgical excision of the lesions, if there are a few, you can try it, you can do curettage and the rest, but at the same time, someone remain with a scar. So you have to assess and see what is the patient wanting. Is it the scar or the lesion itself? So if the scar is better than the initial lesions, then we can try to remove it. Then some other medicines that have been tried include acetretin, the imiquimod, the interferon with retinoids, the topical calcipotriol, and then cementidine. But even the effectiveness and efficacy is still not yet proven, and scanty data is available. So, but most importantly, these patients benefit from sun protection and routine checkup. So if you get such a patient, these are patients that you live with for the rest of your life. I remember one of the cases that I brought was a 23-year-old female that she had acquired form of EDV and had already gotten squamous cell carcinoma on biopsy that was in the preauricular area. So you have to make sure that you screen them more often to make sure that in case there's any malignant transformation, that lesion is dealt with in the due time. And because you know that some of those cancers can metastasize and go to the rest of the body, making it difficult. Then we say annual or more frequent dermatological checkups can even be biannual, so that you keep monitoring the lesions and see how they're changing using pictures. So you take a picture, when they come back, you take another picture, then you can now measure and see how the lesions have progressed or regressed over time. Then radiotherapy has also been tried, and sometimes it is contraindicated for conjunctival squamous cell carcinoma due to the risk of more invasive lesions. So in some cases, if someone already has a SCC, so you can do therapy, you can remove the lesions, and you also do chemotherapy. So what would be the differentials? So in these cases, all the verruca-like lesions can be a differential. So all lesions with hyperkeratosis, parakeratosis, even seborrheic keratosis, actinic keratosis, squamous cell carcinoma, pityriasis, versicolor, all of them are differentials in this state. So as we are concluding, I want you to remember that in EDV, we have a defect in if it is a genetic, we have a defect in the EVER gene, EVER1 and 2, and someone gets persistent infection from the beta type of HPV infections, and that will be the HPV number 5 and number 8, plus all the others that contribute to the rest of the conditions. And someone will have these verrucous flat topped papules and plaques, sometimes with cognarization, and they can be very, very extensive, covering all the body, including the skull. So the onset is usually early, in about 3 to 4 years. Then the lesions can persist with the patients for a very, very long time. That is their lifetime. So we need to be very, very careful when managing these patients. I thank you very much. See you in the next video.